Good morning. I'm Carol Hartigan. Thanks a lot for joining the New England Baptist Hospital Primary Care Physician CME course on practical orthopedics. Today I'll present a talk on narcotic use for chronic low back pain and chronic non-malignant pain. I call it a one-sided debate because I base this talk on a written debate that I was asked to participate in for the North American Spine Society that was published in the Spine Line several years ago that will be provided for your review. My opponent isn't available to present his side of the argument today, but his case for narcotics will be available in that article. So in that article, there was a vignette presented about which we debated where in that article it was a 50-year-old CEO who had 5 years of pain. And I'm just going to talk today about general people who've had low back pain who haven't improved with conventional treatment. Most of these people have had MRIs, CAT scans, EMGs, all kinds of studies, second studies, repeat studies, and in general, for the purposes of this talk, these MRIs and CAT scans have shown changes, bulges, sometimes herniations, but nothing that is dangerous or unsafe. No fracture, no infection, no tumor. 50% of people over age 50 who don't have any pain have a disc herniation. That disc herniation is clinically silent or irrelevant. Bulges can be irrelevant. People who are over 50 can have stenosis. That's not symptomatic. So we don't treat a scan, we treat a person. In any case, as long as it's not dangerous, it's safe. Most of the time, people who've had chronic back pain have had numerous injections. They've had exhaustive injections. They've been around the block with facet joint injections, epidural steroid injections, nerve root blocks, transforaminal injections, and these injections may have provided temporary relief or partial relief, but yet they haven't changed the problem. The person still has pain and still has dysfunction. Most of the time, individuals with chronic low back pain that persists have been around the block also with several courses of physical therapy. And the physical therapy, for the most part, is conventional, and often it's dependent on the pain. Attempts may be made to increase strength or increase cardiovascular function, but when the report of pain is received, the therapists then back off on the expectation or the recommendation to keep moving. And often a therapist isn't working with a physician, so they're not necessarily, they don't feel necessarily confident about challenging the pain. A lot of times physical therapists have given people, have told people that they have things wrong with them, that they're asymmetric, or their leg length is discrepant, or they need to move in a different way, or their SI joint is out of place. This is a letter I received with a new patient I saw recently from the physical therapist. This letter finds all these problems with this person who really has age-appropriate arthritis. This therapist has told me has an unslipped ilium, rotated ilium, a posterior ilium, a stuck sacrum, a coccyx rotation, torsion, positional faults. And so he feels like he has all these terrible problems when really he doesn't. And instead of focusing on what's right, he's been told he has all these things wrong that need someone to fix them and put them back in place. Additionally, people who have chronic low back pain have been given numerous medications. They've been given anti-inflammatories, prednisone, benzodiazepines. We'll talk a little bit more specifically about the more intensive treatments, and of course narcotics as we move along. Because they haven't gotten better, they've seen a chiropractor, they've had craniosacral therapy, sometimes they've seen a acupuncturist, and still they're no better. They continue to have pain, they're disabled, they're avoiding activities, they're not playing soccer, they're not taking out the garbage. These are the things that affect their function. And yet, in the vignette, in the debate that I participated in, there wasn't any abnormality on the physical exam. The neurological exam was normal, the sensory exam was normal. The strength was essentially normal, except in this vignette, this guy wouldn't even try to perform some of the manual motor testing, which suggests that he's fearful and avoidant. His range of motion was impaired. That was really the only other physical examination finding that was abnormal. He couldn't flex more than 60 degrees forward, which is impaired, and that's a result of his avoidance of activity. In fact, given his spondylosis, there isn't a reason he shouldn't have normal range of motion if someone would encourage him to achieve that. So in this case, the question in the vignette was, since he's failed everything else, is it reasonable to start long-term opioid analgesic therapy? Is that advisable since nothing else has worked? My argument will be no. The reason I say no, that long-term opioid analgesic therapy is inadvisable and potentially harmful, is based on some studies. This is a controversial area. There are only a few short-term studies looking at this intervention for chronic, benign, low back pain and non-malignant pain. There are 8 studies that look at for a few weeks and at the most a couple of months at treating people with chronic pain with opioids. All of the 8 studies are pharmaceutical subsidized. 7 of these 8 studies show a modest improvement, not even necessarily significant in most of the studies in pain. 2 of the 8 studies show a mild increase in function. The rest show no change in function and no change in sleep. There are no randomized controlled trials for opioid analgesic therapy for chronic low back pain, for long term. The short term is, there are these few studies. So in Massachusetts, physicians have to attend some opioid pain, continuing medical education credits every 2 years to obtain their license again. So I had to attend this course that was presented by one of the prestigious pain clinics in Boston. And the head of that pain clinic gave a talk about opioids and essentially said what I said. There isn't any evidence that this helps. There isn't any significant improvement in pain. There's no long-term studies. And then this head of the clinic went on to tell the audience how to prescribe these medications for people with chronic, non-malignant low back pain and other pain. So the studies, the short-term studies, look at anywhere from 60 to 180 milligrams of morphine per day. And I like to think of it as Percocet, because we use Percocet, we're all, and Vicodin, which are similar. And oxycodone or Percocet is oxycodone with acetaminophen. Oxycodone is a little stronger in milligrams. So 60 to 180 milligrams of morphine, which is what these short-term studies look at, is equal to 8 to 24 Percocet in the short-term studies. And, 8 Percocet is like if any of us have had surgery, or my daughter recently had her wisdom teeth out, she took 1 Percocet 2 or 3 times a day, and she was pretty much knocked out. So if you think of 24 Percocet, that's 1 bottle of Percocet that would last us after surgery for a week or so. But in these studies, people are taking up to 24 Percocet a day. In the long-acting real world, we see people taking up to 80 milligrams of oxycodone 3 times a day. That's equal to 48 tablets of Percocet. So that's like almost 2 bottles of Percocet, 360 milligrams of morphine, plus they're given short-acting Percocet up to 2 every 4 to 6 hours, which is another 2 times 6, 12, to make it equal to 60 tablets a day for their breakthrough pain. So this is an exorbitant amount of medication. Additionally, they're taking adjunctive medications because they still have pain. They're taking the so-called membrane stabilizers, which is Lyrica and gabapentin. These are medicines that were developed as anti-seizure medicines that were then highly and aggressively marketed by the pharmaceutical industry for off-label use for just chronic they were used for off-label use for pain that wasn't explained, or chronic central pain. But these people are also taking benzodiazepines, which is the Valium family. They're taking tricyclic antidepressants, or the serotonin reuptake inhibitors. They're taking muscle relaxants very often on top of their meds. When I see people, they can come in with these long lists of medication. Flexeril, which is cyclobenzaprine, or Soma, which is carisoprodol. And in fact, though these are called muscle relaxants, and people tell me they're taking muscle relaxants, they do not relax muscle. They are really central nervous system sedatives. I have seen people taking dronabinol, which is basically THC, in addition to all the other meds they're taking. That's supposedly supposed to help pain, which has not been well proven, and there's a whole other controversy about the law in Massachusetts for medical use of marijuana, but I won't even get into that. So then, though these people come in on all these medications, they have very high levels of pain and very poor levels of function. So clearly they're not effective. Again, I refer back to the opioid conference, which I attended, where the experts got up and basically gave the same information that I've given and then went on to tell the audience how to prescribe all of these medications for their patients, how to give drug holidays, how to rotate the meds, even though they're not really necessarily measuring pain and function. One study looked at 196 patients who were using narcotics and found that 1/3 misused the medication. Misuse would be defined as losing the medication, testing negative for the drug, meaning that you're not taking it regularly and possibly you're diverting it or selling it, testing positive for other medications such as cocaine or amphetamines, which are the most common to test positively for, or not showing up for their random drug tests. Another study looked at 200 patients who were taking prescribed narcotics and found that 36% admitted to a history of drug or substance abuse. One study showed that substance abuse was up in the United States between 1992 and 2003 by 140%. Controlled substance scripts were up between 1997 and 2007 over 200%. That was information from the CDC in 2012. The most common desired medications or sought-after prescribed medications are OxyContin and Vicodin. And there are definitely individuals out there who thrive on seeking physicians to prescribe medications by pretending to have an issue. So this is something that I found on the web at a site, alt.dr, where this individual who goes by the web name of Scoremore says if you really want to score, you got to get to a pain clinic and stop begging for 20 Lortabs in the ER. Pain docs don't think anything about writing 100 tabs at a time, sometimes more. You can usually sell back pain, or if you've had surgery, dude, I go to 3 different ones and get 200 bikes, 120 big perks, and a bunch of soma every damn month. So there are people out there who are really looking. However, there are other patients, and physicians give sometimes to people like this, or give to a person one time, and then they'll go to the next physician. But many patients who have pain are actually not seeking drugs. They're victims. They have pain, and physicians who don't know what to do, who don't know how to interpret MRIs, or who don't know that pain is safe and that actually being more fit and active is more advisable than giving medications, just don't have anything else to do but to write a prescription. It's also a great way to get a person out of the office. Oh, here's your new med. Oh, let's up it, let's down it, let's add it, let's subtract it, let's modify it. Many people are just become a victim of this system and are so glad when we can discontinue their pain or taper and discontinue their pain medications. Denmark and Scandinavia have great populations and epidemiologic studies. And this one study in Denmark over 5 years looked at 16,000 people and looked at those with chronic pain. And of the several thousand people in the study who had chronic pain, the recovery odds, the odds of having less pain or no pain after 5 years, was 4 times greater for those individuals in the study who were not using opioids. The opioids using patients with chronic pain had a much greater odds of continuing to have pain. So much for opioids being effective. Opioid overdose correlates with the quantity of the drug prescribed. So increasing the dose makes it more possible to get into trouble with overdose. Interestingly, there are 3 nice detox studies that looked at consecutive patients who agreed to detoxification. And each of these 3 studies show that when people detoxed from their narcotics, their function improved, their activity improved, and their return to work rate improved. In 2 out of the 3 studies of the individuals who came off the narcotics that were used for pain, there was a reduction in pain. There are many, many physiologic effects of opioids, and people with chronic pain have many of the problems that are caused by opioids. Depression is seen in chronic pain, it's caused by opioids. Somnolence is seen in people with chronic pain, it's caused by opioids. Constipation, hyperalgesia, opioids have been shown to make people more sensitive to pain. Opioids cause immune cell dysfunction, and they also greatly affect the hypothalamic pituitary and the adrenal gonadal axis. They cause reduced cortisol, reduced testosterone, luteinizing hormone, estrogen, and progesterone. They increase prolactin and can cause galactorrhea. They cause reduced libido and dysmenorrhea. Sometimes when people are on opioids, I have seen, not infrequently, because of the reduced libido and the sexual dysfunction, application or addition of testosterone or Viagra to treat the effects of the narcotics. There aren't any studies that look at all the polypharmacy of all the drugs that we give people along with the OxyContin and the oxycodone and the Vicodin. So what happens with opioids is that people have pain. They haven't responded to the different treatments. They've failed, and so opioids are added to the regimen. Opioids cause euphoria and improve mood initially. They cause decreased pain initially. They reduce tension and anxiety. Later, by definition, tolerance and dependence develops. The dose gets increased. That causes a new problem. Then when an attempt is made to reduce the drug, there's a withdrawal reaction, increased pain that's attributed to the original pain when it's really a reduction in the dose and the dependence acting up. So there's a vicious cycle. And in response to that, a lot of pain clinics will rotate drugs and modify drugs and give drug holidays, and all of this kind of intervention is not well studied. Prolonged opioid use increases pain sensitivity. People who take opioids have increased blood levels of dynorphin, which is an endogenous compound that enhances pain. Opioids turn on the medullary off cells, so they turn off the signal to pain. They inhibit the medullary on cells, right? The on cells that facilitate pain, so they make us feel less pain initially. When we take the drug away, or in an animal model, if we apply naloxone, then that causes a rebound in the on cells. So we try to get rid of the opioids, and then the on cells get facilitated so we have more pain. And the body gets totally confused. Additionally, exogenous opioids alter endogenous opioids, and if we're taking exogenous opioids, we develop a cross-tolerance, so we don't respond to our own endogenous opioids. So it's a big problem to come off the medication. If by chance we do feel that a person, I don't necessarily agree to this, but in the case that we did want to use opioids for treatment of chronic non-malignant pain or chronic benign low back pain, then they should be always prescribed according to the recommendations of the American Academy of Pain Medicine and the American Pain Society consensus. There should be treatment goals. There should be an opioid agreement or contract between the physician and the patient. Pain and function should be measured. The dose should be started low and kept moderate. No one should get up to 80 milligrams of OxyContin TID. The drug should be discontinued if the pain and the function do not respond. We should avoid unproven adjunctive medications and polypharmacy and cocktails of medications. And we should always include a random screen and a toxic screen, no matter who the individual, no matter what their walk of life. One physician should prescribe, not a rotation of physicians. So many pain clinics all across the country have patients come in with very complicated problems, see a different pain doctor every time, and that doctor doesn't know the patient individually and just does something, anything to respond to whatever the patient's reports are that day. So in the case of chronic low back pain that's benign, that has failed conservative treatment, I don't endorse the initiation of opioids in spite of the lack of treatment response. I like to recognize that the anatomy is usually benign, or in this case would always be benign, that the range of motion is poor, that by definition people with chronic low back pain are guarding, their muscles are tense, they're deconditioned because they've been avoiding activity. By definition, these people with chronic pain have central sensitization, so the pain signals that have been transmitting to the brain have now caused the brain to be in a hyperactive state and respond disproportionately to any true insult. These people with chronic back pain have usually received mixed messages, and often messages that something is wrong. They've had all kinds of diagnostics and interventions. If they shouldn't have opioids, should they have surgery? Should they have more therapy? Let's look at some of the studies asking this question. There are 3 studies looking at surgery versus physical therapy. The first one is from Sweden in 2001, and they're looked at about 600 patients who were either randomized to a group that had surgery or a group that had rehab. The problem with the study is that the rehab group had conventional rehab, the rehab I talked about in the beginning, which is hot pack, ultrasound, get on your back, do a pelvic tilt, do a knee to chest, really very non-challenging therapy. And the surgical group received surgery. 60% of the surgical group was better at 2-year follow-up, 36% returned to work, and there was a 33% reduction in pain. While in the control group, 30% were much better or better, and only 17% returned to work. So it looked like the surgical group did better at 2 years, but the problem with the study, again, is that it was conventional rehab. So then, as intensive rehab began to develop in 2003 in Norway, one study randomized patients to either a cognitive rehab and progressive exercise, 3 exercise sessions for 3 weeks plus cognitive behavioral education that the pain is safe, that it's advisable to exercise and be active even if there is pain, versus a posterior fusion group. And they published a study at 1 year and then again at 4 years showing that both of the groups had essentially the same significant improvements in low back pain and disability, significant reductions in analgesics and distress, and that both groups were equally satisfied and had equally returned to work. There wasn't any difference between the groups in this study. So this was a more intensive physical therapy with a message to be moving and be active in spite of the pain. Then in 2005, another study came out that looked at almost 400 patients and randomized them to either, again, an intensive exercise group with cognitive behavioral education or surgery. And at 1 year, the outcomes showed that both groups had significant improvements in their Oswestry disability score, their SF-36, and their walking test, and there wasn't any difference between the groups. The last study I'll mention, and there are others, but this is a relevant study, is looked at 223 patients in the Netherlands. It was published in 2006, and they looked at 4 groups, 3 treatment groups versus a waiting list group. The treatment group was either active physical therapy or cognitive behavioral therapy, and cognitive behavioral therapy was the message that your pain is safe, what are the things you like to do, what are the negative things that may provoke your pain, what are the things you could avoid that may be playing a role, or active plus cognitive behavioral therapy. And all 3 of the treatment groups compared to the waiting list groups showed significant improvements in pain and function, while only the active and the active plus cognitive behavioral therapy showed physical performance improvements. So the cognitive behavioral intervention helped pain and function, but not the physical performance, the measurements of strength, flexibility, endurance, and cardio fitness. We wrote a review article that was published in the Spine Journal looking at exercise as treatment for chronic low back pain, and we concluded that there's a lot of evidence in randomized controlled studies demonstrating that there is significant improvement with non-pain contingent intensive resisted exercise program versus low intensity or conventional treatment. And the studies show 30 to 80% improvements in flexibility and strength, 30 to 54% reduction in pain, up to 56% improved disability. And we actually did a study where we treated people with intensive rehab, and we just looked at their depression scale, the Beck's depression scale, before and after treatment, and found a significant reduction in depression, though we weren't actively treating depression. And all of these studies show improvements are maintained at 1 year follow-up, so it's not just short-term post-treatment response. In conclusion, there isn't any evidence to support the benefit of opioid treatment in chronic low back pain or chronic non-malignant pain. The long-term effects of chronic narcotic use are negative and include all of the negative effects that we discussed. So it is reasonable and appropriate to pursue non-pain contingent, quota-based, cognitively oriented, intensive rehab for people with chronic low back pain that is benign who have failed other treatments. Other rehabilitation interventions are usually not as intensive or challenging as this type of treatment, and significant improvements in pain and function can be expected. These are my references. Thanks very much, and thanks again for joining the New England Baptist Hospital Primary Care Physician Practical Orthopedics CME course.